we now conclude our first session and we'll begin with the plenary session and have the ANTC panel discussion on the topic, who should admit and treat head trauma patient with or without polytrauma. I invite the chairpersons for this discussion, Dr. Yogi, Dr. Wilko Paul and Dr. R.C. Mishra to take to the stage. I request Professor Deepak Gupta to moderate the session. Our first talk will be by Dr. Subodh Garg.
Everybody can take their seats, please. I think in the next couple of hours we'll have some offbeat topics for discussion, and I would require full participation from the audience for this discussion, because these are the things which are extremely common and we face it day in and day out. I'll just run through 4 or 5 slides, and then we'll have a discussion or presentation by various members, and at the end one of my colleague, Dr. Kamaljit Garg, will present the results of the survey which we conducted in our country for the same. I'll just begin with a very short video of Professor Brian Janet. Can I have the audio also on this? Just listen to it very carefully, please. And this video was shot, I think, 15 or 20 years back.
Maybe head injury first. Where do you see head injury going? Well, I think that neurosurgery started with head injuries, you know, arrow wounds in the Chinese dynasties and Aztec holes in the skull, and it'll end with that because, you know, tumors is going to end up with immunology or chemistry or, you know, it's not going to be hacking it out, I don't think. And I think that trauma will always be with us. There are fewer head injuries thanks to preventive measures, but given man, there'll always be head injuries. So I reckon it's a long-running serial, and therefore we should always have to deal with it. And so I think there are, of course, emerging now a whole generation of new drugs.
So the message was very clear almost 2 decades back by nobody else than Brian Janet, who devised the Glasgow Coma Scale with Graham Teasdale. Head injury is going to stay with the neurosurgeons. It began in the neurosurgical profession years and years and years back, and it is continuing on with us. Now I just quickly run through this very short case. A 30-year-old male patient, he had a history of trauma 7 days back. He presented to us with a full score, and E-fast was positive, and there was no history of loss of consciousness. Please note it down. Casualty notes were there, and the CT abdomen shows presence of bladder injury. CT head was not done at that time. Patient was taken for emergency bladder repair, was doing well. Post-op was uneventful. Patient was planned for discharge, and this I'm talking about a case in a level 1 apex trauma center wherein all infrastructure is in place. Patient was planned for discharge, but then patient was complaining of nagging and persistent headache. And so on post-op day 6, a neurosurgery consultation was taken, and for this is what we had. Patient had a large extradural hematoma, and it was operated well in time. So things do happen at times, even when you have the strict protocol in your center. Sometimes there is a breach in the continuity of care, or some protocols do happen. Now in the COVID period, many of us played dual roles. You know, we were probably surgeons, we were being asked to manage medicine cases and other cases, and somehow I played the dual role of a COVID warrior and a COVID caregiver at the same time. I spent almost 2 months in the ICU, almost 4 to 6 to 8 hours every day with my mother those days, and I closely observed what was happening in the ICU those days. So I personally believe is this dual role, is it a necessity or a need? You know, when you go to the public setups, these are the 3 scenarios which you commonly come across. A severe traumatic brain injury patient comes to you with abdominal injuries requiring conservative treatment with a normal CT scan. Who should admit? Who should manage? There is a fight of cats and dogs between the surgeons, orthopedicians and the neurosurgeons on this. Second scenario probably is a severe trauma patient comes to you with polytrauma, with a normal CT, with femur fracture. Who should admit and manage? Naturally, the orthopedician will say no. The moment the patient is unconscious in a ventilator, they will say no. Third scenario is, should hospital policies be changed where TBI is still managed in the polytrauma ICUs? I'm aware of the big institutes in our country, in the reputed center, and Dr. Vanan will vouch for that. There are many centers in our country wherein the neurotrauma, the head injury patients are being operated by the neurosurgeons, and they are being managed by in the surgical ICU. What happens to those patients? Let's say if the patient becomes M1, people don't even notice when the person actually reaches to a brain death stage. So they just get unnoticed. So that is something which is very common. Now if you switch the situation to the private setups, where of course the finances, I mean, let us accept this brutal fact, finances are involved, so there is a role reversal. Everybody wants to admit the patient of whatever the specialty is. Like, let us say if I'm a neurologist and a trauma patient comes to me, I'll admit the patient under my care, I'll have the maximum cut. So, I don't even know whether this picture is true or not. We'll hear it from our experts, what do they have to say. So what we did was we gathered a group of, actually I also looked for the neurologists, somehow I could not get them on the board. So we have Dr. Subodh Kumar, he is a general surgeon with expertise in trauma surgery, he's working in trauma center for almost 2.5 decades with us, he was my senior resident. Then we have Dr. Harsh Sapra, he's an intensive care specialist. Then we have a neurosurgeon on the board, Dr. Varnan Bello. And lastly but not the least, we have a unique personality. He is not only a neurosurgeon but also a neurointensivist who could probably give us a dual picture of what is happening. So without wasting any time, I'll first call upon Dr. Subodh to share his views.
A very good morning, and at the outset I would like to thank Dr. Deepak Gupta for giving me this opportunity. And before I start, I just want to quote a statement made by Dr. Deepak in 2007 when we returned from Israel and we were young, and I quote, "I went as a neurosurgeon, but I returned as a trauma surgeon," unquote. He is as much a trauma surgeon as I am. And we are working together as a team in the trauma center, saving lives. I'm not going to give any debate or speech here. I'll give you some facts and figures to establish the role of trauma surgeons in managing head injury patients with or without polytrauma, without undermining the role of neurosurgeons, intensivists, critical care experts. I have high regards for them. So I'll start with the case scenario. 28-year-old male, road traffic injury, four-wheeler, hit a four-wheeler. Primary survey was done, hemodynamically stable, fast negative, E3, V5, M6. We know it's a mild head injury. CT scan, SDH. At the same time, CT torso was done, and he had blunt trauma chest with rib fractures with minimal hemothorax. Who should admit this patient? I don't want any answers from you. Case scenario 2, 18-year-old male, RTI, hemodynamically stable, fast negative, E4, V4, M6 with hematuria. Intraparenchymal bleed, grade 4 renal injury. Who should admit this patient? 30-year-old female, RTI, three-wheeler overturn, heart rate 114, slight tachycardia, BP is slightly stable, fast positive, E3, V4, M5, contusions, grade 4 splenic injury. Who should admit this patient? All these patients are from our trauma center, and all were admitted under trauma surgery, and thankfully all were discharged in a stable condition. We sought the neurosurgery opinion. No neurosurgical intervention was done in these patients, and they were discharged in a GCS 15/15. This is our data of last year. Whole spectrum of cases were admitted under trauma surgery. It's around 8% of the patients, they have associated head injuries. And this is our comparison, yearly comparison from 2014 till date to last year, and it's around 8 to 10% patients who are admitted under trauma surgery have associated head injury, mild to moderate. So what is the current scenario in that we know, and I discussed with Deepak also, that up to 95% of the patient can be managed non-operatively, with only 1% of all polytrauma patients or 2 to 4% of head injury require some kind of surgical intervention or even ICP monitoring. And I asked him how many neurosurgeons we have in India. He said close to 3,500 in India with a population of 1.4 billion. So one neurosurgeon for 400,000 population. Do we need more? Let's see. It's a very interesting paper presented in 2016 in AAST conference. And I read out, it's a multi-institutional study to see what is the outcome of head injury patients, whether managed by a neurosurgeon or a neurointensivist or a trauma surgeon and trauma ICU, and then concluded that multiple injury patients with TBI have lower mortality risk when admitted to a trauma ICU. This survival benefit increases with increasing injury severity, meaning thereby the more the injury severity score, the chances of survival are better if these patients are admitted in the trauma surgery ICU. Isolated TBI patients have similar mortality risk when admitted to a neuro ICU compared with a trauma ICU. So same. But medical or surgical ICU admissions, means non-trauma surgical ICUs, carries a slightly higher mortality risk. Another very important paper. Do we need a neurosurgery consultation, a repeat CT scan, because these patients require most of the time, so they should be admitted under neurosurgeons? No, you can always call them and take their opinion and get the CT. Because in this study they said all the patients had neurosurgical consultations. Patients with mild TBI with isolated subarachnoid hemorrhage generally have a low morbidity, shorter length of stay, and negligible mortality. So why do we need a neurosurgeon? Less than 10% of this population had worsening of their head injury on repeat CT scanning. Given the low acuity of these patients with SAH and tendency towards resolution without intervention, acute care surgeon can manage this specific group of patients with TBI without routine neurosurgical consultations. Repeat CT scanning continues to have the utility as it may identify new lesions, deterioration, or need further management. I have a couple of slides more. Do we have enough neurosurgeons? I was looking for data from India, but I found it very interesting. So I made a comparison. So it says that every year an estimated 22 million patients suffer from neurological disorders, non-traumatic, as well as injuries that warrant expertise of a neurosurgeon, of whom 13 million require surgery, both for traumatic injuries and non-traumatic injuries. Traumatic brain injury, stroke-related conditions, tumors, hydrocephalus, epilepsy constitute the majority of essential neurosurgical care worldwide. Approximately 23,000 additional neurosurgeons are needed to address more than 5 million essential neurosurgical cases, all in low and middle income countries. India is a middle income country, that go unmet each year. There exists a gross disparity in the allocation of surgical workforce, leaving large geographic treatment gaps, particularly in Africa and Southeast Asia. Then I googled what is the population of Africa. It's 1.4 billion. And the population of Southeast Asia, India is a part of South Asia, right? Southeast Asia population is 68 million. So combining the two is 2 billion. So we need 23,000 more neurosurgeons for 2 billion population. So taking this analogy, we have 3,500 neurosurgeons in India for 1.4 billion, and I leave it to your fine sense of judgment how many neurosurgeons more we need in India. So that's my take-home message. Ideally, all patients with TBI, no doubt about it, it's a teamwork. Trauma care is a teamwork. With GCS less than 15 should receive a neurosurgical consultation. Considering the dearth of 24/7 neurosurgeons to tackle all TBI, especially in low and middle income countries, it is reasonable that trauma surgeon can manage polytrauma patients with mild or selective moderate head injury cases not requiring surgical interventions. However, close monitoring is imperative and neurosurgical consultation to be sought as and when required. Thank you very much.
Thank you, Dr. Subodh, for such an excellent talk. I think we'll have all the 4 presentations and then we'll take up discussion. Next, I call upon Dr. Harsh Sapra. Let's hear what the intensivist, critical care medicine, and probably on behalf of the anesthetists and neuroanesthetists, he'll give a combined talk.
So, good morning everyone. Thank you Dr. Deepak for giving me this chance of representing the critical care community. So, first I want to ask, how many of you have tumor board meetings? How many neurosurgeons? And how many of you have trauma board meetings? Just 2 of them. Trauma rounds, but do you have trauma board meetings? No. Okay. So what we all agree upon is that TBI should be attended in specialist critical care units, be it neurocritical care units, be it trauma units, but not in general ICUs. The RAIN trial has shown so. It has shown the outcomes are better. It has shown the cost adjusted to estimates is the same as general critical care units. But one thing we don't agree upon is who should look after head injuries in neuro ICUs. So implementation of various strategies to prevent secondary brain injury due to hypoxia, hypoperfusion, that includes ventilatory strategies, fluid management, seizure control, osmotherapy, assessment of intracranial pressures, use of multimodal monitoring, both for neurological and physiological needs, prognostication, rehabilitation, and optimization of general physiology and disease-specific management is required, and so is the management of metabolic stress. So what is it? Ideal or ideal? So this is the open unit. The neurosurgeon admits, provider throughout the patient's stay, other specialty teams consults are giving on a day-to-day case basis, and I don't know who collates this information. So that's the American Association of Neurological Association and Congress of Neurosurgical Surgeons position statement, where they quote, neurosurgeons are fully trained in neurointensive care by reason of training, program requirement, and upon completion of training are competent to independently manage and direct treatment of patients with neurological disorders requiring critical care. Additional training in critical care is optional, but is not necessary for neurosurgeons to manage neurocritical care patients following residency training. So sometimes because of overconfidence, you can have to eat through a straw. So it is essential that neurosurgeons are proficiently trained and educated in evaluation and management of these patients both before and after surgery, especially in the critical care settings. And why am I saying so? Because there's always another story. There's more than what meets the eye. So you have neurotrauma, you have cerebrovascular injury, you have seizures, you have cardiovascular, pulmonary, renal, GI, hematological, immunological, you have checklists, you have bundles, you have guidelines, you have protocols, you have evidence-based medicine. How many times have we seen a young enthusiastic neurosurgeon pushing the patient from the triage for an extradural without a trauma protocol done and finding a pneumothorax or a ruptured spleen? I think this story is not unheard of by any of us. And what about the various gametes? Are we all proficient in using everything? Are we all independently capable of doing everything on our own? Do we have enough numbers in the country that one person can deal with everything? I don't think so. What about monitoring? What about Dopplers? What about NIRS? What about ONSD? What about cardiac monitoring? What about airway? What about near airway techniques? What about fiber optics? What about your ventilation? What about your ventilatory strategies? What about the feed? What about your lifelines, your line placements? What about your prophylaxis? What about your, turning the back to bed sores and things, So you need somebody to look after all these things. So why neurointensivists than only neurosurgeons? It's a subspecialized and highly trained group, knowledgeable about neurological pathology, familiar with the unique physiological considerations, well-trained in a variety of neurointensive care unit procedures, and can act efficiently to prevent secondary injuries in the post-operative or intensive care settings. Their presence can make the unit become more focused towards neuroprotection. Treatment targets like the blood pressure targets, the temperature targets are consistently chosen with the aim of preventing secondary injury and increasing with the aid of advanced multimodal monitoring. Furthermore, they are well equipped to deal with non-neurological organ dysfunction that can be encountered in critical, it's most of the times encountered with critical care, TBI patients. Additional benefits is reduce in length of stay, cost savings, less need for, the studies have shown in VP shunts in SAH patients, improved documentation and increased organ and tissue donation rates. So it is time to move on. It's the we team and not the me team. We over me. In the 21st century, critical care is a well-defined specialty. When we look at our times, we need to put a premium to the care of patient first and leave politics and turf battles behind. Neuro ICUs provide a unique classroom in which all practicing specialties, neurology, neurosurgery, anesthesiology, critical care can draw insights, better appreciate and manage various aspects of the whole TBI process. The neurointensivist can teach the neurosurgeons develop systemic approach and to work cooperatively in multidisciplinary teams. Collaboration between the neurocritical care team and neurosurgical team includes residents at all levels is needed to optimize both flow and clinical education. Standardized daily rounds are necessary. Neurosurgeons and neurocritical care teams meet to discuss the plans. In our hospital, we do have a trauma board meeting where there is a combined chart where all the stakeholders sit down together and discuss the protocol of the patient and discuss what would be done throughout the day, and that is appraised to the relatives as well. And neurosurgical presentations by residents dealing with important neurosurgical considerations to the entire neurocritical care team is done. The neurocritical care team observes neurosurgical procedures, and there are scheduled lectures by the neurocritical care teams for the neurosurgical colleagues. And what is the closed cooperative neuro ICU model? One in which the neurosurgery or neurology service continues to have an active role in the management of patients, and the neuro ICU team handles the day-to-day affairs of the patients and the minor procedures. So what constitutes the we team in our institute would be the neurointensivists, the neurosurgeons, neurologists, radiologists, pharmacists, physician extenders, your nurse practitioners, the critical care nurses, respiratory therapists, rehab, and the social workers. So this is what I want to end with. It doesn't matter whether you are the captain or a deckhand. All hands must work together to save to save a ship in the raging storm. Thank you.
Thank you so much. I'm sure there are a lot of bubbling questions, including me. I mean, we have many questions to you. We'll ask at the end. Next, I call upon Dr. Varnan Bello. He is from Mumbai, JJ Group of Hospitals. He will talk about neurosurgeons' perspectives.
Can I have my presentation? Thank you, chairpersons. Thank you, Deepak, for inviting me. What I'm going to do is I'll just highlight the scenario in Maharashtra and Mumbai. Can I have my presentation? So basically, it's not a talk just to tell you a short story and then what happens really on the ground, at the ground level. Mine is in that same folder, Dr. Vernon. Yeah, go up to head injuries here. We go into slideshow. Okay, everybody faces this problem. So the statistics in Mumbai, you see we are a large population in Mumbai, and head injury accounts for 11% of the total deaths, and on an average it is 1/5 of the nation's head injuries. And we have many centers, sub-centers, medical units, primary health centers, rural centers, but finally we being tertiary, just like you all, we have to bear the brunt. All these patients, somehow they end up coming to us, and then there is a big line for their admissions. Then we don't have beds, we don't have ICU beds, and we cannot fill our whole wards with just head injuries. It is impossible. So then we have to take the help of the orthopedic surgeons, we have to take the help of the general surgeons, and sometimes even physicians, because nobody is willing to admit them, and we just can't manage with this overload. We only take the patients who have to be operated. Those who have not been operated are sent to general surgery, and that's why one of your residents is here who has been stimulated by neurosurgery, and she's doing neurosurgery names now. She was our general surgery resident before, and she has seen that scenario and she's got awakened by that. That is a good thing. So we are the tertiary center, and then we have the BMC hospitals who also share the brunt. So each one would have been doing 1,500 to 1,800 trauma these cases in a year. And but maximum number of patients being public hospitals, we bear the brunt because they come as unknown. And when they are unknown, the public gets them. No relative comes with the patient to the hospital. And if you go to a private hospital, first thing they will tell you, pay the deposit of 1 lakh. So no public person will have 1 lakh in his pocket to, even if he's a well-to-do person, if he's found on the railway tracks, it's the public or the railway police who get them straight to the government hospitals because of the payment issue. So this is a technical issue, and very few might go directly to the hospitals, and some go to the nursing homes, which I will tell you. So this is how basically how we scan them when they come to the casualty and take their details, and these are the head injuries which we normally see. And if you see, the mortality is quite high because they are all severe head injuries in these patients. Most of them are head injuries which require surgery, because we admit those who require surgery. There would be another 1,000 in a year which were on the medicine or surgery or the orthopedic side, which I have not included here. So these are the number of deaths which can occur. So it is quite significant if you see here from the amount of patients who are admitted. And then you have the same thing with spinal cord injury. If you see, the spinal cord injury is worse than the head injuries. If you see the deaths in cervical, upper cervical cord injuries and cervical spine injuries, many of them, they just go and they're all young patients. So who should treat head injuries? I think it should be the neurosurgeon, which is the most ideal situation. Then trauma surgeon with experience of neurosurgery, which is already been explained. And if these are not available, then the general surgeon who has had some experience also comes in handy, and then the orthopedic surgeon, because in a scenario where we have more people getting injured and less specialists to treat, that is the only way to go to save lives. So here in Bombay now we have different scenarios. We have the medical colleges, we have the private hospitals, and then we have even people who are admitting like BAMS, BHMS. They are also admitting patients in nursing homes, and they would not want the patient to be taken away from them. They would insist that these neurosurgeons who are in practice come there, operate, and they go. And then they say, no, you keep the patient on our side. We want to treat this patient. And it becomes very difficult, because if you don't listen, they will call another neurosurgeon who is much junior, and they will do it. So they want the surgery done, and many of them are owners of these nursing homes. So they don't like patients to be, if you say refer the patient to JJ hospital, they will get very upset. And then from tomorrow, they will not call that guy who is doing private practice there in the nursing. So this is the scenario. And sometimes the lack of facilities and lack of training, which affects this golden hour of traumatic brain injury. It's all, you know, I would say useless waste of time. There is no proper time which has been managed there, and then the patient comes to us, he's already half coned, he's already decerebrating, and then we cannot do much for these patients. So what is an ideal situation? It should be a mechanism where complete treatment of head trauma is given at an earliest in a fully equipped setup, having adequately trained staff, nurses, and doctors. So that is sometimes a dream, especially in our country because of the population. So basically it involves three phases. You save the life of the patient, you got to maintain that saved life, and then reposition that patient back in society, which we are not concentrating much upon. We are only in the part one part of it. The second part of it, yes, we are there somewhere, but in the third part, we are not at all involved, whether we are trauma surgeons, neurosurgeons, orthopedic surgeons, or as physicians. So, Deepak, this is for you. This is for you. I think the time has come where you should be having neurotraumatology as a separate field. It should be a degree. It should be an MCH degree. And it should be a separate field because, see, we come from an institute where I'm dealing with aneurysms, skull-based tumors, CP angle tumors, and then head injuries. Yeah, so head injuries become, for me, as a HOD, I leave it to my juniors, I leave it, it is the cutting of the residents. The head injuries who come in the night are operated by my residents. But of course, I know that if I was there, maybe I could have done it better. But we get involved, I think it's the same thing here. We get involved only if it's a VIP with a head injury or an MLA with a head injury or some doctor's relative who has come, only then we are involved. But normally it is treated by the junior cadre, which is not so good in my opinion. But I cannot help it because I have to handle the aneurysms and the skull base next day. So basically it is not one-man show, it is a complete, teamwork. But the best thing for trauma would be to be segregated completely. It should be a separate field and it should be a separate specialty. That is what I think the future lies. Thank you.
Next I call upon Dr. Matthew Joseph. He's a very unique person in our country. He's a neurosurgeon and we all have learned from him, but now for the last many years, I don't know the exact duration, but for the last many years, he's a dedicated neurointensivist. So I think he'll be able to give us a balanced picture. Sir.
Okay, the first part of the statement is true. I did train in neurosurgery. Calling me a neurointensivist is being very kind, because I have no training in neurointensive care. I learnt on the job because there was nobody else. When I started looking after my ICU patients, I was an incremental neurointensivist. When I finished my neurosurgery, I was interested in trauma. And most trauma is non-surgical. So I had to learn how to handle the ventilator, how to handle the monitor. Then neurosurgery said, since you know how to do it, when you look after our sick patients as well. And then neurology said, since you're doing neurosurgery patients, look after neurology patients as well. So I became neurointensivist purely by rule of thumb, fingers, toes, everything. You cut off my digits and I cannot be neurointensivist. Okay, I've really learnt purely empirically on the job. My theoretical knowledge is quite poor. So this is purely an opinion piece. I'm not giving any numbers for this. Okay, so if you have an isolated TBI, who do you have to have? You have to have a neurosurgeon. All right? In charge? Probably yes. Alone? In most cases, yes. Not all. Because sometimes even your isolated TBI will have other trauma you haven't picked up, or will have medical problems that you're not quite sure how to handle. Your patient comes 13 by 15, is on these multiple medications. Am I up to date on the latest things for hypertension? I'm not. You know, which drug is good, which drug is bad, which drug will interact with mephenidine, which drug, I don't know. Okay, I would like to have an opinion coming in, but I wouldn't mind being overall responsible. When you have more medical issues, ischemic heart disease, etc., coming in, then again your want for input from somebody who knows how to think that way, from an intensivist or a medical person, goes higher. And once it comes to multiple system trauma, again, if you've done it a lot, you can do it, but you will never be as good as somebody who's made it their primary specialty. All right, so I'll go through one by one. A neurosurgeon. Okay, I still remember the sheer desperation I felt. I was doing a long distance train journey in the year after I finished my MCH. And my stupid travel agent has booked me as doctor. So the TT came from 7 coaches away saying there's an old lady there who's got chest pain. My first reaction was call a doctor. Okay. Yeah, what do you know after you finish 6 years of MCH, what do you know about treating chest pain? Nothing. Nothing. So I was walking down this corridor, in this vestibule of the train, desperately trying to remember something from my internship, which is obviously not there. And when I reached this lady, she said, I had some tea and I'm feeling better. I said, keep drinking tea, and I ran back to my berth and never went there again. Yeah? But you really don't know. When by the time you finish a neurosurgery, you're so involved in neurosurgery. If you want to start doing critical care and stuff like that again, it requires a huge amount of involvement from you because you have to stay up to date with your specialty and acquire knowledge from new specialty. It is a separate specialty. Critical care is a separate specialty. It's not something that you can do instinctively based on your knowledge. That used to happen. When I was training, there were no intensivists in the ICU. Each unit looked after their own patients. But now I know it's wrong. All right? So I am not good enough alone. Okay? If you've done your MCH after doing general surgery, possibly you are reasonably competent dealing with multi-system trauma, but not the critical care part of it, not the medical part of it. A general surgeon does know all the systems. Okay, I'm talking about general surgeon, but trauma surgeon, is good at doing systemic stabilization. Could that general surgeon make decisions on whether to operate for the head injury or not? Maybe a very vastly experienced person would, but take an average general surgeon, average trauma surgeon, and ask them to make a decision, okay, this CT scan, midline shift was 3 millimeters, now it's 5 millimeters. Should we operate? Yeah. If there is nobody else, yes, they would make the decision. But in an ideal situation, you would like the neurosurgical input into that as well, not have them alone. Should the general surgeon operate, do the actual surgery? You know, there's lots of debate about that. I'm not going to get into that. Should a general surgeon be allowed to do extra-axial hematomas? I'm not going to get into that debate because that's a huge, often very acrimonious debate. I don't want to get into that. But, you know, ideally not. Ideally, surgical decision and surgical intervention should be done by a neurosurgeon. Intensivist knows, you know, overall can handle a patient much better than any surgeon can. Okay, it's a fact of life. I mean, I'm not being unnecessarily flattering to intensivists. It's a fact of life. You can't get that kind of knowledge because their knowledge base is comes from a totally different place. They're used to looking at a patient as a whole, whereas all of us are used to looking at a patient as a head with a body attached somewhere which you're not really interested in. Yeah? So neurocritical care is a huge different specialty. Even from general critical care, very different from neurosurgery, very different from anything else. Most experienced neurointensivists do have some basic neurosurgical knowledge. But again, would I be comfortable if my family member was being managed by a neurointensivist who makes the decision whether to operate or not? Again, probably not. Okay? I would leave surgical decisions to the people who are trained to do it. And the people who are trained to do it are neurosurgeons. So, ideal world, everybody works together. We have that to a certain extent where I work now. Only for the last 4 years we had a trauma team. So now the trauma team sees every trauma patient, evaluates the multiple, stabilizes in the ER. In the emergency, the patient is stabilized. The patient goes to the trauma ICU. Patients who have been identified as isolated trauma and head injuries come to the neurotrauma ICU. All the others with significant systemic injuries go to the trauma ICU. We consult down, they consult up. Okay, they're on the ground floor, we're on the 4th floor. We consult up and down quite regularly, every day. Every day I do morning rounds, 9 o'clock I do in the trauma ICU. Okay, it's working well. The basic medical care in both the ICUs is provided by the intensivists. The basic ventilation, you know, maintaining nutrition, infection control, everything is done by the intensivists. We are, you know, I don't know, epiphenomenon, whatever. We also are there involved in the care, but the primary day-to-day care is done by the intensivists. Okay? It doesn't matter who the patient is under. We checked, when we were trying to form a neurotrauma unit separately, we checked with Dr. Girish Menon. I don't know how many of you know him. He's done a formal law training as well. And he quoted us some cases, etc., which said, as long as a neurosurgeon participates in the care of a patient, the patient does not have to be admitted under neurosurgeon. A head injury patient can be admitted under anybody as long as the neurosurgeon participates in the care. Okay, that's the legal situation in India right now. So nominally who the patient is under doesn't matter. All right? Thank you.
Thank you so much, all the speakers, for sticking to the time. I'll give you a very simple, if I can ask the neurosurgeons, how many of you know what is hyperchloremic acidosis and how to manage that? Trust me, I just see one or two hands, because I'm dealing with the brain death day in and day out. We see, patient actually is being given normal saline infusions, and patient, because of the normal saline infusion, who is having polyuria, he goes into metabolic acidosis, which is hyperchloremic. And the treatment of choice of that is not the giving more and more fluids, because normally, your sense of understanding is anybody in trauma who is having metabolic acidosis, you give some more fluid. He's probably dehydrated. And then you give more, and then it just takes away the buzz from your hand. So these are the things which you can understand only when you are in the neuro-intensive care ICU and dealing with the patient. I have a question to, I will open it, if I open it to the floor, this discussion can go on till the end. And I think, Dr. Subodh, the ideal situation which you described, what we have in Jayaprakash Narayan Apex Trauma Center, what has actually happened that it has not percolated to the rest of the country? Why the government of India has not been able to initiate, there's so many trauma centers in our country, why our role model, the model which we have, has not happened maybe across the street also?
I think I just want to correct you. We don't have so many trauma centers, dedicated trauma centers, or labeled trauma centers in the country, right? So probably ours is the only standalone trauma center in the country. Yes, everybody is managing trauma. That's a different story, right? I think it's a mindset, right? So I would like to answer in three ways. Now there are some efforts going on, and 3 academic programs are currently running in India to bridge this gap. And I was fortunate to be part of all the 3. One, we are running this MCH in trauma surgery and critical care at AIIMS New Delhi, and 3 other AIIMS, AIIMS Rishikesh, AIIMS Jodhpur, AIIMS Patna. We have a fellowship in trauma and acute care surgery of the National Board of Examination, of which this neurotrauma is a part of the curriculum. And third, there is a postgraduate course, MS in traumatology and surgery, is running at 3 places in the country, and CMC Vellore, I think soon, by next year, they will start this program, of which this neurosurgery training, the neurotrauma in particular, is the part of this program to deal with the non-operative management of these patients and to identify the patients who require a surgical intervention by a neurosurgeon, and in the absence of a neurosurgeon, in a desperate situation, if possible, then they can do, quote unquote, a decompression.
How many trauma surgeons we have in our country as of today, if I may ask?
Are trained neurosurgeons. So when we started this program, 2016, those who are trained as a trauma surgeon, we have currently 30.
30? So you are just 1% of the neurosurgeons.
No. So I'm not a trained trauma surgeon, right? Yes.
Is
I'm asking you, I'm telling you the 30 years. So because 30 passed out in last 8 years, those who have a degree of MCA trauma surgery and critical care. Yeah.
Just a question, because I like this discussion, and I have to be very humble like my neighbor, because I'm living in a very rich neurosurgical world. But if you have this issue about who is doing what, and you have the golden standard here, working closely together, why cannot be there a training module that traumatology and neurotraumatology is one specialism, what is promoted by VELAR? So what is your opinion as a trauma surgeon? If you would say that, and you stand on the podium also in Europe and the US.
Yeah, that's what, it's a great question. So that's what I was replying to. So yes, there is a need, and there are some efforts going on. See, our country, everybody is a degree oriented. Everybody wants a degree to be labeled as a trauma surgeon or a neurosurgeon or this thing. Just by training or managing the trauma patient doesn't make you a trauma surgeon, right?
Matthew doesn't have that degree.
No.
But he's still doing
Can I
it.
have Kamaljeet here?
The psyche of the doctors in India is that.
Sir,
they want
actually
some kind
this
of injury,
discussion
right?
is centering not at the ideal centers.
No.
There are very, very less ideal centers in our country. We are talking about sub-ideal conditions which are prevalent in rest of the nation and probably in rest of the world.
Actually, we are trying to answer a political question through science.
Through science.
Yes, you may put it in a very
I think
humble way.
you are
I accept
absolutely-
it.
Absolutely right.
So what is your take on that?
My take is just for the, it should be patient-centric approach. If we are patient-centric and we have multiple heads, then we should all apply together for the benefit of the patient. If we seek the answer through science in the political scenario, which is entirely different from the public and private institutions, we will not be able to.
Sir, at the end of the day, there is something which is called as a responsibility.
Ethics.
Who takes the responsibility if the patient dies? Who is the admitting person? Who should take the maximal decision for the patient? If there are multiple people involved in the team, there is only one person who is in charge of the patient. And let us say the patient dies, whose legal responsibility is?
You see, if it is a legal word, then each and every person who has been involved with treatment is responsible.
No, sir. No.
That does not happen usually.
No.
Can I answer?
Yes.
Just quickly. I was a chairman of the disciplinary committee of Delhi Medical Council for 5 years, and you are absolutely right. So anybody who is involved in the care of the patient, it doesn't matter that he said who is the nominal in charge, irrelevant. Yes. If you have seen a patient only once,
Yes.
and if your name is there and you have put in a
Then
note,
legally
you
you are
are
responsible.
equally responsible for the care of the patient.
So a message is,
You are absolutely
the
right.
message is everybody should put down the notes.
sir. In the court of
Everybody
law,
should
it
put down the notes in the case. That's what Dr. Mahapatra used to talk about. Anybody who is being consulted, they should come down and put down the notes in the patient file for taking the responsibility. Before we open it further, I just call upon Dr. Kamaljit Garg. We recently did a very short survey in our country. We sent it to the surgeons, intensivists and the neurosurgeons, and let's see what he has to say.
Thank you, sir. I'll present briefly the preliminary results of a survey which we started about 10 days back. Can I have my slides? So till now we have received 82 responses. The topic of the survey was this, that who should admit and treat TBI or head trauma with or without polytrauma. Out of these 82 respondents, about 50% were neurosurgeons, and the rest of the respondents belonged to neuroanesthesia and critical care. 16% were trauma surgeons and about 10% were neurologists. Most of the, around 40% of the respondents were from the age group 35 to 45, and around 60% of respondents were working in private hospitals. And most of the respondents were taking care of good number of, were working in high load centers. We asked the respondents about their opinion that who should admit the TBI patients. And 70% of the respondents believed that the patient should be admitted under neurosurgeons only, while 30% believed that the neurosurgeon should not be admitting these patients. And then we asked what happens actually in practice, and then it was found that 81% of the respondents was told that the TBI patients are admitted under neurosurgeons, and 11% of patients are admitted under trauma surgeons. And the predominant reason of this, that the trauma patients are not admitted in neurosurgeons, was the non-availability of a full-time neurosurgeon in the centers. And that is probably true for many small private centers where neurosurgeons go whenever they are called for. And then we try to check what are the practices, what are the routine practices, whether they are followed diligently in the centers. And GCS monitoring pupillary assessment, which routinely we recommend hourly assessment, especially immediately after trauma, were followed up only in 36% of the respondents. And there were like 11% of the respondents who don't get routine imaging following any trauma to rule out traumatic brain injury. And decisions regarding repeating CT scans in ICU patients were taken by neurosurgeons in 75% of the centers, while critical care team was taking this decision in 18% of the centers. And the patient with TBI admitted to ICU were primarily managed by neurosurgeons in 62% of the centers, while 34% were managed by critical care team. And following cranial surgery in the postoperative period, neurosurgeons managed patient in 70% of the centers, while the critical care team managed these patients in 28% of the centers, while the long-term follow-up was with the neurosurgeons only in majority of the centers. I think that's it. Thank you.
Thank you so much, sir.
Thank you,
Before
Karan.
One quick question. When I took the survey, I was looking at the survey, I was looking for the results. How many people own their own hospitals and their own CT scanners?
We didn't check.
Thank you. Friends, people tell me, you don't want neurotrauma, but we need it to pay our bills, keep our own private nursing homes open, and pay for our CT scanners, etc. There's a problem. 2 points. 2 points. That issue of owning your own CT scanner, your own hospital is self-serving, can cause a lot of confusion. And friends,
Unethical.
dear medicine people of motherland, you will change, just like we did in America. When you have one lawyer, you have a broken, poor lawyer. When you have 2 lawyers, you have lots of rich lawyers. Friends, medicine in India will change in the next decade as people will get sued for things of management. As R.C. Mishra just pointed out, in America, there's nothing wrong with seeing your name is on a lawsuit, you're number 14 on the list. And you don't number the patient, but apparently somehow you saw a note or you looked at something. That will change how neurosurgery, neurotrauma is managed. You will see, maybe that should be part of your training.
Thank you. I think one very important message from Matthew Joseph was, I am not good enough alone. I think this is all we should remember, because we have to work together as a team with keeping the egos aside on one side. And if you have got somebody who has got slightly having an edge over you in certain parts of management of a care, you should take that person, join hands and work together. Before I close, one statement that we have actually submitted the proposal to our institute for starting fellowship in neurotrauma post MCH, and it is still in the Dean committee, and probably we will start the fellowship in neurotrauma post MCH. Dr. Mahapatra has to make a comment.
About 15 years back, I told there should be trauma MS. That 3 years of MS, 1 year general surgery, 1 year orthopedic surgery, 1 year neurosurgery. Because that's the time when we are supposed to have trauma hospitals in golden quadrangle, all big cities. If you are planning a trauma hospital in the highway, then you should have MS trauma surgery. Out of 3 years of training, 1 year general surgery, not MCH. 1 year MS, so that way I told in 2009, I was chairman of postgraduate committee of MCI, but it was not accepted by the chairman. 1 year general surgery, 1 year neurosurgery, 1 year orthopedic surgery. If we can train quickly MS trauma surgery, then we will have hundreds of people. If you go for MCH, nobody will come after MS general surgery.
Thank you, Dr. Mahapatra. Thank you, Dr. Mahapatra. Dr. Harsapra, how many neurointensivists we have as of now in our country? If I may ask you.
In my institute, we have 20 of us practicing.
No, in India per se, I mean, because you were the...
So it's a budding field. When I came back from the UK in 2009, I think very few countries, very few hospitals were running, separate neurocritical care units. AIMS, Vellore, there were a handful of them, Shri Chitra. So now I think the numbers increased. If you look at the figures of the Society of Neurocritical Care of India, that's the SNCC, there are around 550 or 600 members. And if you look at SNAC, there are around 1,000 members. So typically, purely trained in neuro would be around 1,000, 1,200 people.
Dr. Sharath.
One more thing is that they have to write discharge summary. If they want to admit the patient, they have to go to casualty. See what is happening? Just they want neurosurgeon to admit, they will see, neurosurgeon go back, they will discharge, they will follow. If a person takes the responsibility of treating from beginning, go to casualty, make the MLC, treat in the ICU, take in the ward,
So that's an unending debate as of now, and there is no end to it.
And push it to the box to the air, so you attend the MSc.
We have to close the session. Dr. Sharath and then Dr. Dwarka, no further questions, please.
No, you are post casualty.
So just one comment. So just one comment. We have had an excellent discussion. We have been speaking so much about training more manpower. But if you see today, the reality is most of the tier 2 or even tier 3 cities have enough neurosurgeons. So even a place like Jabalpur has 25 neurosurgeons. And many of them are frustrated because there are not enough infrastructure which is developing. So I think when we push for more manpower, both the infrastructure as well as the manpower should be pushed simultaneously. Because there's no point, training somebody and they don't have a place to work.
Absolutely. The interest has to come for neurotraumatology, as Banan Velu rightly said. Dwarka, last comment.
There are some 4 comments. One is neurointensive care is a separate field. I mean, we should not confuse it with anesthetists during neuroanesthesia and critical care. It's like a neurosurgeon also doing neuro care. Anesthetist doing the same. So there should be a dedicated neurointensivist. And most of the centers, especially at NIMHANS, the fellowship in neurocritical care is open to MCH neurosurgery, DM neurology, as well as DM neuroanesthesia. So that is one point. Second thing is, the point why neurosurgeons are not going into critical care is very difficult for a qualified neurosurgeon to do only neurotrauma. And I think even the JP and ANTC neurosurgeons also have the same problem. If you tell neurosurgeons that you will do only trauma for the rest of 40 years, nobody will stay in that place.
So
for the rest of their life.
70% of our load of neurosurgery is neurotrauma. Large part of our load is pediatric neurosurgery. These are the two things which are grossly neglected and taken as below the stature kind of a jobs. I think this is somewhere we need to create more neurosurgeons. I think we will close it with this. Last comment, please. We are getting late by 35 minutes, we are delayed.
The problem with admitting patients is because it becomes more of an ego issue and saying that, and commercial interest saying that this patient should be admitted under me, so I should look after it.
Yes.
I think all of us should realize
Be on the
that
same page.
finally at the end of the thing that it is not me who...
It is we.
All of us together should treat the patient. And one thing which all of you forgot to mention in this debate is the debate about pediatric patients less than 5 years. They have a completely different physiology and compared to the adults, and that is a completely separate area of debates.
We have Dr. Thomas Nakagawa from Jacksonville. He's a pediatric critical care intensivist. Sir, do you want to add to this discussion or?
Wait for your talks.
We've made life easy. Kids are cared for in typically 1 or 2 pediatric ICUs. Cardiovascular ICU, there are neurocritical care units that are being established across the United States. They are few and far between. I think the important thing to remember is that the intensivist, the hospitalists, and the general trauma surgeons all tend to be generalists. We work from head to toe. We're not organ-centric, we're patient-centric. And I think that that's the important thing. In medicine today, compared to when I started years ago, back in the 1980s, not the 1880s, 1980s, there was a point in time where physicians took care of the entire patient regardless of who they were. Today it's much different. We just take care of our own specialty. The cardiologist takes care of the heart. The neurologist takes care of the brain. The gastroenterologist takes care of the GI system. The nephrologist takes care of the kidney without regard for what happens to the rest of the body. And that's why intensivists become so important, because we take all that information from everybody, we synthesize it, and come up with a plan together with everybody that works for the patient, not for an organ, but for the patient.
Thank you so much for the comment. With this, we close this session. I think the survey which we have made, we will be sending it to everybody, and maybe some of you will respond. We will come up with some better conclusions. Thank you, chairpersons and the audience, for your patient listening. We now go to the next session. Nidisha, over.